two distinct conditions, but there is quite an interplay between the two, and we'll have a little bit of a chat about that. I think kind of the way we're going forward, it will probably have a bit of a mixed audience. So I'm sure a lot of you are very educated about what endometriosis is, so I can skip over that quite quickly, and then we'll go into the diagnosis and the management options for endometriosis. Obviously, this is as a whole, and you've got to keep in mind that every person who comes in with this condition kind of has to tailor it to their personal circumstance. And then we'll be talking about polycystic ovarian syndrome in its own individuality, and then talking about the two and how they might interplay with each other. So endometriosis is a chronic inflammatory condition. 1 in 9 people who are born female at birth are affected by the condition. And it's quite a higher prevalence in those with other conditions. So we know it can affect fertility. So in somewhere like a fertility clinic or someone who's suffering from subfertility, about 30 to 50% of those people will have endometriosis. The main symptoms of endometriosis, as I'm sure you're all well aware, pain is the predominating symptom, and subfertility is another sign that people present with as well. Or there's a reasonable portion of people that may have it but are asymptomatic or don't have any symptoms. It's quite a debilitating disease. Fortunately, it's gotten a little bit more awareness recently, but it has a huge impact on quality of life, physical function, education, social relationships, as well as work and intimate relationships as well. And as I'm sure, unfortunately, a lot of people have experienced, is a big delay to diagnosis. So the average is about 8 years. And that's probably multifactorial. From our point of view, from a doctor's point of view, I don't think there's been enough awareness about it and asking people questions about the condition. Also, there's been a normalisation that painful periods are normal and therefore people don't present to their doctor, but there's quite a few factors that contribute to that. The big common misconception with endometriosis is we talk about surgical stages, so stage 1 to stage 4. There's actually no correlation between the stage of the disease and pain symptoms. So someone can present with stage 1 disease and have severe pain, whereas someone with stage 4 disease can be completely asymptomatic. So I apologise if people don't like surgery photos. I've just got a few quick things, but it's the best way to show what endometriosis is. So this is a normal laparoscopy with a normal uterus, and you see that shiny peritoneum over the pelvis. And you compare that to endometriosis, where it causes these black lesions or scarring. So this is quite severe disease, probably deep infiltrating endometriosis. But there are some superficial deposits there as well. And you can see some superficial deposits there on the bladder. It can be quite subtle, so we do recommend if someone can go in and say they have a normal laparoscopy, but if you look closer, there are signs of endometriosis. So I do like to take a biopsy as well, so that the pathologist can have a look at that under the microscope and tell us for certain, is it there or is it not? But they are pretty telltale signs. And in someone who does endometriosis surgery all the time, in the laparoscopy, where they say there's no evidence of disease, that is very accurate to say there's none there or there is some there. Other more significant types of endometriosis are collections in the ovaries or endometriomas. So this is collection of the endometrial material within the ovary, and there's a few theories as why this might happen. The initial theory of endometriosis was retrograde menstruation. So instead of the menstrual blood passing through the cervix, it goes back through the fallopian tubes and binds to areas in the pelvis. That can explain a reasonable amount of endometriosis, but not all of it. For example, people that have a hysterectomy is not completely curative of endometriosis. So you say, look, where did that endometrial tissue come from if retrograde menstruation should explain everything? And more recent research has said there's quite a few different causes for endometriosis. So some cells within the ovary can change the type of cell they are into endometrial tissue, or we think there's probably some spread through the lymphatic vessels and through the blood vessels of the microscopic endometrial tissue, and that can implant elsewhere. And that more fits with patients who have endometriosis well away from the uterus. So some people get it in their lungs, it's been found in joints, on fingers. So there's not all, it's most likely a few different diseases, and we're putting it all into the one thing and calling it endometriosis. This is deep infiltrating endometriosis. So some people might be familiar if one of your practitioners has requested a deep infiltrating endometriosis ultrasound. This is looking for larger areas of disease. So on the left here, we can see it's not completely clear, but the bowel is pulled up and adherent to the uterus, or within the wall of the pelvis or within the bladder, there's collections of endometriosis, and this is a severe form of the disease. This can be missed on a basic ultrasound. So your standard ultrasound, where they, I like to say to my patients, where the ultrasound place does hips, knees, shoulders, and some gynecology scans, they might look at the uterus and say, look, the uterus is normal and the ovaries look normal, but we really want a more in-depth look at that. And a trained person who does gynecology scans all the time will be able to pick up this type of disease where otherwise it might not have been picked up before. And then if you're comparing the left to the right, so this is the normal pelvis at laparoscopy, and this is the uterus. This is the uterosacral ligaments behind the uterus, and the bowel is kind of down here, well out of the way, and that's the top of the vagina there. And you can see here, this bowel is pulled right up, and that's because we get the impression that there's a nodule or a collection of endometriosis between the rectum and the vagina. This is the same thing, but with the bladder. So you see a lot of that scarring signs of the signs of bladder disease there. So just a quick rehash on what we mean when we talk about staging of endometriosis. So this can range from stage 1 through to stage 4. I like to think of stage 1 as your small deposits of endometriosis on the pelvis, maybe some scar tissue that's forming. Stage 4 is big endometriomas or collection in the ovaries, and what we call distortion of anatomy. So when there's a lot of things stuck together, so the bowel is stuck to the uterus, the ovaries are stuck to the uterus or to the side of the pelvis as well. And again, this is kind of useful for us as surgeons to kind of explain to people what we saw, and it can relate to fertility, but from a symptom point of view, there's no correlation. Some people can have very severe symptoms with a very minimal quantity of endometriosis, and it doesn't really matter about how many lesions there are. So more when you see your doctor in the clinic, they'll more importantly ask you about what your symptoms are and how bad they are, instead of concentrating so much on the ultrasound. The ultrasound can be helpful if you're having surgery, but apart from that, what's important is the symptoms people are getting and how we can help people with those symptoms. So the general symptoms for endometriosis, these are a very wide range of symptoms, and they're not specific. So not specific meaning that there's not a typical 1 or 2 symptoms of endometriosis where someone comes in and they report those symptoms and you say, look, you must have endometriosis. There's a big variety of them. So this can range from pelvic pain, which can be your typical endometriosis pain is a cyclical pain, so pain around the time of the period, and especially pain in the days leading up before bleeding starts is a typical sign of endometriosis. Painful periods as well, but there can be a range of other symptoms. So pain across the abdomen, shooting pain down the legs is a really common one. Fatigue is a really common symptom we see. Bowel dysfunction, so that's ranging from constipation to diarrhea and other bowel dysfunctions. And there's a really big interplay between patients who have endometriosis and irritable bowel syndrome as well. So they often occur together, or those symptoms can mimic each other. So someone who comes and presents and feels they have endometriosis, they have surgery, and it's not there, they end up being diagnosed with IBS and vice versa. Other signs of significant disease are pain with intercourse, and that can be for a few reasons. That can be because a few of those ligaments we're talking about here, the uterosacral ligaments, can really commonly get endometriosis on them. The majority of time, that's where some of the disease is, and that can cause pain with the intercourse because that's just the top of the vagina just there. But also quite significant pain, and we'll talk about this a little bit later, can cause a lot of tensing of the pelvic floor and an overactive pelvic floor, and that's over-tensing of the pelvic floor can contribute to pain as well, and can cause significant pain with intercourse. And that's why approaching this from a lot of different angles to help with the symptoms, especially with the physiotherapy, can help with those type of symptoms. So from the symptoms, we can say someone has possible or they have likely endometriosis. You can't tell it definitively unless an ultrasound or an MRI shows obvious big collections, but that's only going to be in your more severe stages. If you look at how else can we diagnose the disease, there's been a lot of research recently on biomarkers. It's a very exciting area of research. Could we possibly diagnose people with endo and they don't necessarily need surgery or laparoscopy to say definitively. It would be great if we could. At the moment, it's not possible, but there's a lot of promise here. And maybe in the future, people will be able to have a blood test or a saliva sample, and that will tell, are you likely or not likely to have endometriosis? And imaging, we spoke about. Imaging can be very useful to show severe disease. It can be useful to show other possible causes of pain, such as a cyst in the ovary. In my setting, it's more useful for planning for surgery. So an ultrasound can kind of give an idea of how severe the disease is, and it allows me to counsel patients about what their risks of surgery are and what their benefits might be. MRIs we use sometimes. They can be useful for more severe disease for surgical planning. Or if the patient, like the person coming through, doesn't want to have an internal ultrasound. So if they don't feel comfortable with that, if they find it the actual ultrasound too uncomfortable or painful to have, then an MRI can be useful, but it's a lot more expensive to have done. And the gold standard is laparoscopy. So have a look with keyhole surgery and see if there is endometriosis or there's not. We used to say, look, everyone has to have a laparoscopy, but now we're really moving away from that. And I think the less surgery we can do, the better. Some people want to know definitively, do I have endo or not? And that's completely reasonable. But often the approach now is to say, look, you probably have endometriosis. Why don't we treat it as if you did anyway? And let's start some of that medical therapy to see if we can improve your symptoms, and we can hopefully avoid surgery. And if your symptoms don't improve with that medical treatment, then you look at surgery for diagnosis and treatment at the same time. So how do we treat endometriosis? This is very multifactorial. So there's a lot of contributing things and a lot of problems that endometriosis can cause. So at the very basis, it's people who present with painful periods or pain before their period starts. We've got to look at managing that. The other tricky one is people who start to develop pain at other times in their cycle. So if the pain isn't just isolated to the menstrual periods, then you can treat the menstrual periods or try and stop them, but there still might be an element of pain there. So we've got to look at how do we manage that as well. Neuropathic and nociceptive pain. So I don't expect anyone to remember what these terms are, but basically a lot of the research recently has shown that endometriosis isn't just causing scarring in the pelvis, it's also affecting the nerves and the lining of the nerves and cells called glial cells, which occur throughout the nervous system. And what can happen with your nerves is like to explain to people, when someone breaks their arm, and even just touching the skin over the top of their arm becomes incredibly painful when that shouldn't be painful. A similar thing can happen in the pelvis. So nerves are firing off to respond to stimuli that shouldn't be painful, and it's saying, look, there's pain here. Or nociceptive pain is your nervous system is starting to develop pathways saying that pain's happening and there's actually nothing happening to cause that pain. And this unfortunately can be a complication of long-term inflammation and pain as a result of endometriosis, and can be a bit more tricky to manage, but very well managed in collaboration with a pain specialist. Pelvic floor dysfunction we spoke about is related to the increased tone or tensing of the muscles of the pelvic floor, and a physiotherapist is excellent to see about this. Endometriosis can cause fertility issues, so it's important to look at other causes of subfertility, so do other tests to make sure the semen analysis is normal, making sure the fallopian tubes are open before just saying, look, this is definitely because of endometriosis. But then if you look at, could endometriosis be contributing to subfertility, how do we go about potentially improving that? So for early stages of disease, a laparoscopy and treatment of endometriosis does improve pregnancy rates for people struggling with pregnancy issues. And for more severe stages of disease, so the stage 3 and 4 we were talking about, surgery doesn't really improve pregnancy rates, but it's an indicator that people with that stage of disease having trouble falling pregnant might need fertility treatment with IVF. And the other thing is seeing the patient or the person presenting as a whole. So people who present with pain as a result of endometriosis, the pain is definitely not in their head, but it can really deteriorate their mental well-being. As we spoke about, it has such a huge impact on people's lifestyles, their relationships. And it can really detriment their mental health long term. So it's really good to have touch with a counsellor or a psychologist can be really helpful, just to touch base on a regular basis, just to check everything's going okay. And if someone does have certain mental health conditions that were there beforehand, like anxiety or depression, they're especially at risk of the symptoms of endometriosis really affecting the mental health. So it's really important to be involved with a mental health practitioner as well and have that as part of the treatment plan. And just at the bottom, I've just got chronic pain. So when I refer to chronic pain, it's technically pain that's been occurring for more than 6 months. So most people who have endometriosis, because of how long we've taken to diagnose it, have had it for 8 years, as we said before. But what chronic pain more refers to is when you've gone from that cyclical pain or the pain occurring with the periods to you might now have a daily pain that doesn't go away, or that kind of shooting pain across your abdomen is a sign that your nerves in your pelvis are probably getting affected as a result of the endometriosis. But treating the endometriosis will only partly treat that pain going forward. So you've got chronic pain management is again a multifactorial thing to try and improve pain through a lot of different avenues that we've just spoken about, and that's best done through management with your GP and a pain specialist as well. There's quite a few around Perth. So just a little bit on surgery for endometriosis. So it's a treatment option. It's not the only treatment option. Generally, we used to have a lot of people that their doctor would recommend surgery every 6 months, and we see them and they've had 15, 20 laparoscopies before. And the recent evidence is really trying to move away from that for a form of management. Ideally, if you can avoid surgery, that's ideal. If we can manage with medical management, so hormonal treatment or non-hormonal treatment, and then reserve surgery for those people that either don't want to or can't take that hormonal treatment, or despite taking it, they're still getting significant pain. And if you're going to do surgery, you want to do ideally one surgery and that's it, and definitively treat all of the endometriosis. And the best way to do that is, in my opinion, is to see a practitioner that just does endometriosis all the time in that type of surgery. And what they'll be able to do is they'll be able to adequately do an appropriate workup before surgery. So order the right ultrasound or MRI to tell to what extent of endometriosis there is. And they'll also be able to, based on those scans, be able to talk in depth about what the risks and the benefits are of surgery. I think what we didn't do so well before is give people a realistic expectation about how surgery can improve things. And understandably, people used to come after an operation and the pain didn't improve, and they said, well, I thought it was supposed to get so much better with surgery. So I like to tell people that about 70% of people who have surgery for endometriosis, their pain will improve. And that doesn't, I mean, it depends how you look at it. It's not 100%, so it's not fantastic, but 70% is reasonable. But that also includes people who have tried a lot of different other treatments, such as the pill or hormonal treatments and pain relief, and are still getting pain, and then surgery can still improve the pain for those people. So it's a pretty good outcome, but it does mean 20 to 30% of people won't get an improvement with surgery, and a very small portion of people, surgery will act as an extra flare on the nerves in their pelvis, related to that neuropathic pain we were talking about. And unfortunately, in about 1 to 2% of people, surgery can make their pain worse. That's the statistics for your first surgery. If you need more and more surgery, sometimes you do need it. If you need more surgery, we try and not have them too close together. So ideally at least 5 years apart. And with each subsequent surgery, it's slightly less likely that it improves your pain, and slightly more likely that, slightly higher than that 1 to 2%, that it can actually make the pain worse. But the other thing about seeing a practitioner that does only endometriosis, or a large portion have done some advanced surgical training, is you really don't want to see someone, you go in, do a laparoscopy, and they say, hey, you have quite significant endometriosis, I'm not comfortable to treat this. And then you have to see someone else and have another surgery. That's really not good practice. And so we're trying to move away from that and really subspecializing to have people who do a high volume of surgical procedures. So those who have had an advanced fellowship in laparoscopic surgery doing the majority of endometriosis surgery. Hormonal treatment. So some people love it, a lot of people hate it. Unfortunately, it's all that we've got for a lot of the treatment of endometriosis. And it would be nice if they had less side effects, but unfortunately a lot of them do. But again, about 70 to 80% of people, their pain will improve significantly on hormonal treatment. Some people express some concerns about taking hormones long-term, and a common perception I get is people come in and say, look, it can't be healthy for me to be on hormones long-term, such those high levels. The things I reiterate is with things like the combined oral contraceptive pill, the pill isn't designed to give you an overload of hormones. What happens normally in your menstrual cycle, I haven't got a slide in, but I probably should have, is there's a huge variation in estrogen levels and progesterone levels. So they're the hormone levels happening throughout your body every month. And so when you add something like the pill, you're not adding an extra load on top of that because there is such a huge variation. What you're adding on is a small dose that's just constantly, but it's nowhere near those big waves, and it stops that huge cycling of hormones. The idea of the pill for endometriosis is it thins out the endometrium and the endometriosis, and in that way it reduces the amount of inflammation and scarring. And it is very effective long-term to help with endometriosis type pain. So things like the combined oral contraceptive pill, there's always a new one that they say is fancy and it's amazing, and it just happens to be 4 times the cost of other pills. There's no evidence that one contraceptive pill is more effective than another. So what I like to do is just start something that's been around for a long time, you know that it's safe and it's cheap, like Levlin, and see how things go. Some people find they get significant side effects on the pill. I try and encourage people to try and take a little bit longer. You do need to take the pill for at least 4 months in order to down-regulate the receptors within the pelvis to try and reduce the growth of the endometriosis. So if it didn't work the first month, there's a good chance after 3 or 4 months you still will find significant improvement. And sometimes people, if they get significant side effects, it's not that you say, oh, look, can't use any pill, because different side effects happen with different pills. And for people who are managing this long term, they might find they need to try 3 or 4 different types of the pill until they find one that works for them and causes less side effects. Other treatment options are the progesterone-only pill. So some people can't take estrogen. So if you suffer from a migraine with an aura, so what an aura means is when you have your headache of a migraine, if you see a straight line and it has all blurry lines outside it, hypothetically your risk of a stroke with the pill is a little bit higher. So it's recommended you don't take the estrogen, so you just take the progesterone, and these are incredibly effective for endometriosis. Some of the newer ones have really good evidence. So Copson is an excellent tablet for treatment of endo. There's a new one called Slinda. It's a different type of progesterone, is very effective. And there's other types of progesterone as well. So the depot injection every 3 months is very effective, the Mirena as well. And I've listed Zoladex down there. It's a bit more in-depth for people with quite severe disease, but it's not a hormone in that it's not adding on hormone levels. What it does is it shuts down the ovaries, so it stops the release of estrogen and progesterone directly in the body, and is very effective to treat endometriosis. Unfortunately, the side effects are related to how it works. So it might sound familiar to people, is basically the ovaries shutting down is what menopause is. So the side effects of Zoladex are menopausal symptoms such as hot flushes and problems with the sleep as well. There are some medications you can take to reduce those symptoms if you're using Zoladex. But that's probably a bit more of an in-depth chat with your practitioner, and there's not a huge portion of people that would require Zoladex for endometriosis treatment. We look at treatment of pain. So these are non-hormonal options. So simple things I like to use: regular Panadol, anti-inflammatories. Anti-inflammatories actually have the best evidence out of any pain relief medication for endometriosis, and you can buy them over the counter, so Nurofen. Some people come in and see me. They're people that have more severe disease. So we look what can be more effective, and suppositories are very effective. So Voltaren suppositories are really good for those severe exacerbations of pain that last for a day or two. And how do we try and get over this hump so we can still catch up with our friends, still go to work, and not be in bed for the day? And they are really effective, but they're suppositories that go in the bottom or the rectum, so they're obviously not very comfortable to use. I do avoid opioid medication in endometriosis. I don't think it's sustainable long term. A lot of people come in taking Panadine Fort. Panadine Fort has been shown actually long-term to be associated with worse pain outcomes than not taking Panadine Fort, so I avoid that. But it can create problems with constipation and reliance on those opioid medications as well. So I don't prescribe them as part of my practice, but a lot of people will take them short-term for really severe bouts of pain. So we spoke a little bit about neuropathic or nociceptive pain. So this is quite a complex theory. Don't expect anyone to understand what's going on in this picture. But basically it's when nerves in your pelvis have a heightened pain response. So something that's should be a little bit uncomfortable, but not necessarily painful. They start firing really rapidly and say to your brain, look, there's a lot of pain here. Or things that shouldn't cause pain, such as menstruating or growth of some small endometriosis lesions or ovulation. Your brain fires and says, hey, this is painful. And nociceptive pain is referring to when there's no stimulus there, but your brain's kind of had this response in the past about ongoing pain in the pelvis, and it's firing up saying, look, there's something going on here causing pain. This can take a little bit longer to treat and is best done in collaboration with a pain specialist. So there's quite a few in Perth that do a lot more related to pelvic pain. And what they look at doing is it's using a number of things. So medications is one. And there's some medications that used to be used for other purposes, such as some antidepressants, which bind to the same receptors that help treat pain. It's also about other pain management strategies. So a lot of this is about education, which a lot of it is available online about how to get through certain episodes of pain, but there's really good evidence for things like mindfulness and meditation as well. And the goal here would really be say, hey, maybe we can't take away this pain completely, but how do we still function with some element of pain that's going on? And with the medication, so the medication that used to be used as antidepressants, but is very effective for this type of pain, is nortriptyline and amitriptyline. They're generally taken at night time because they can cause some drowsiness. You generally start them at a low dose, take that dose for about a week. If it's not really providing pain improvement, you can increase it slightly the next week and keep going up until there is a maximum dose for them. If they cause too much drowsiness, you tend to go back to the dose you were taking before. Pregabalin and gabapentin, I don't use them so much, but some pain specialists do. As I said, a lot of management from a gynecology point of view is we can initiate some of this medication, but it's more in the realm of the pain specialist to have ongoing review of these things. And I think that's a really important part of the management, is being engaged with the pain specialist, especially for the people who suffer from pain almost every day. The pelvic floor dysfunction we spoke a little bit about, so seeing a women's health physio, if you're fortunate enough to have access to one. There's not so many in rural areas, but sometimes we'd say make an appointment with someone in the city, or even a phone appointment, or ask if they know someone in your area, because often in some of the bigger hospitals they do have women's health physiotherapists, and these they can do an examination or an ultrasound to assess the pelvic floor and give you like a treatment strategy or plan to try and reduce the tensing of those muscles. And they can also run you through certain pain management strategies and an exercise program that won't flare up your pelvic pain. So looking at low impact exercise like walking, cycling or swimming, as opposed to high intensity exercise. For treatment of fertility issues, this can be quite complex and is really an individualized approach. Just to reiterate, endometriosis can affect fertility, but most people with endometriosis do not have fertility issues. So it is a small portion of people that do have this. It's important to not just say, oh, it's because of the endometriosis. So look at other possible causes. So is there an issue with ovulation? Is there an issue with the semen analysis? Are the fallopian tubes open? Surgery can improve fertility. So in people with stage 1 or stage 2 endometriosis, so early on stages, surgery for removal of lesions has been shown to improve pregnancy rates. For stage 3 or stage 4 endometriosis, surgery probably doesn't improve the chance of falling pregnant naturally, and these people might need fertility treatments. If you have a big endometrioma on the ovary, that is good evidence that if you treat that, that does improve pregnancy rates. but surgery on the ovary can affect the overall egg count as well. So it's just talking in a lot of depth with your practitioner about what the benefits and risks are of surgery in this situation. And we spoke a little bit about mental health and well-being, but it's just that daily pain or even pain every month can have a severe impact on quality of life. So making sure you've got good support structures around you. I recommend having a regular psychologist or therapist that you see. And they can also, if you see a psychologist that is skilled with trauma-informed care or with pain management especially, they can teach you a lot of methods regarding pain and how to manage these longer term. And chronic pain we spoke about can be a little bit more tricky. So when you say chronic pain, this is long-term pain more than 6 months that might affect things on a daily basis. And maybe endometriosis was the initial one of the causative factors. But even if you treat the endometriosis completely, there still can be an element of pain there. And that's about just having a lot of people of support around you. So a gynaecologist to help with the endometriosis point of view, a pain specialist, a physio, a psychologist as well. There's a few alternative therapies which maybe don't have a huge amount of evidence, but they're not necessarily harmful. And some people find they do help. So things like acupuncture and other type of Chinese herbal remedies. There's no solid evidence that they're beneficial, but we don't have evidence on a lot of things. And as long as they're not harmful, then you can try them. There's a lot of good education things online. I'm sure everyone's experiences a lot of information out there that's not necessarily correct from blogs, etc. So I really encourage people to go to an informative source like Endometriosis WA or Endometriosis Australia. There's the Jean Hales Foundation, pelvicpain.org.au, and there's some online pain modules as well to learn a little bit more about pelvic pain. So that kind of winds up endometriosis. It's difficult to cover everything in 30 minutes to 40 minutes. So just a bit of a skim over the top, but please do ask questions at the end if you've got any specific questions at all. Talking a little bit about polycystic ovarian syndrome. So talk a little bit about it in the management, and then we'll talk about the interplay with endometriosis. So polycystic ovarian syndrome is usually found on ultrasound. It says as polycystic ovaries. So what that means is there's lots of small immature follicles within the ovaries instead of the 1 or 2 dominant follicles that are about to cause ovulation. And this can be a really, it is a really complex condition. I don't think we fully understand it, and we haven't really understood it very well until recently. You definitely don't have to remember all of these receptors and all these pathways, but basically what polycystic ovarian syndrome is it's a complex genetic trait that's passed down that causes problems with ovulation and menstrual dysfunction. And the large relationship of what it does is your brain usually releases some hormones that act on the ovaries, and it's an abnormally high amount of one of these hormones that makes the ovary not ovulate or release an egg in the normal manner, but it can also cause abnormal steroid release as well, and that can place people at risk of other conditions, which we'll talk about. So it's pretty common. Different literature says ranges from 6 to 10% of the population, so pretty huge. And there's nothing people have done to cause it. It's no necessarily lifestyle things to make them higher risk. It's just, unfortunately, some people develop it. We don't fully understand why, but they'll probably learn that there's genes that they'll identify that are associated with this condition. So the signs and symptoms people might get, so trouble falling pregnant, and that's related to the frequency of ovulation or how often an egg is released, which should happen about once every month. But people who have polycystic ovarian syndrome might not have their period every month. Some people have it every 3 months, or it's usually very irregular. Some people don't have it at all for a year or 2 years. Because of the abnormal steroid release, there's higher levels of testosterone. And so testosterone is, you're probably aware, it's high in people who are male at birth. But it's also present in people born female at birth, but it's just high levels of the testosterone, and this can cause excessive hair growth and acne or skin changes as well. A really common thing people report is menstrual irregularities, so a cycle which ranges from 28 days to 60 or 90 days, or not menstruating at all. And when they do menstruate, they get very heavy and painful periods. polycystic ovaries on ultrasound, it's a sign. It's not really a symptom, so people don't usually know it's there apart from the symptoms they're getting. Obesity, unfortunately, is a lot more common in PCOS, and that's because of the different hormones that are released make it really difficult for someone to stay within a healthy weight range. And it's a lot harder for these people to lose weight, and it's a lot easier for these people to put weight on as well. And that can be one of the really hard things about PCOS. And related to the difficulty losing weight and putting on weight, they are more prone to diabetes, but also in a separate way, even within a normal weight range, diabetes still is more likely in people with PCOS. So a lot of our treatments, the treatment goals really concentrate around how do we improve these symptoms for people. So the treatment goals, the priority for people are treating their excessive hair growth and treating acne, to monitor for diabetes, and I recommend a diabetes screen at least every 2 years through the GP, and regular monitoring of blood pressure as well. So every year you should get your blood pressure checked with your GP, and that's because a few of these are combined risk factors for heart disease, and high blood pressure is another risk factor, so trying to reduce that as much as possible. The other thing is with irregular menstrual cycles and irregular ovulation, people with PCOS are at higher risk of some abnormal changes to the lining of the uterus, so precancer or cancerous changes. So a lot of the treatment is based around trying to reduce that risk as much as possible. And a lot of that is through hormonal treatment, which we'll talk about. Contraception is an important one. So you say, look, I thought you just said that it affects fertility, and it can, but some people time kind of intercourse at certain times of the month to reduce the chance of pregnancy. But if your ovulation is random, so if you might be having your period once a month or once every 4 months, then you don't really know when that time is. So contraception is an important one. For people who have issues falling pregnant or want to try for a pregnancy, assisting with that is a priority as well, and regulating the menstrual cycle. Again, to help with the risk of the uterine cancer, but also because just to make it a little bit more planned or scheduled, so people don't have any idea of having a menstrual period at completely unexpected times. So a lot of the treatments around PCOS are lifestyle changes. So regular exercise, 30 minutes a day, at least 5 days a week of moderate intensity exercise. A dietitian can be really helpful. And a lot of these are based around the fact that for people who are at a higher weight range, so BMI above 30, with 5 to 10% of weight loss, the majority of people will return to having a regular menstrual cycle and ovulating at a regular time. So lifestyle factors are really a main part of the management of PCOS. These things, exercise and diet, will also reduce the risk of heart disease and diabetes. But this is tricky, and it's a long-term management thing. Other options are oral contraceptives, so if not trying for a pregnancy. And it's also to reduce the chance of the precancerous or cancerous changes of the uterus. And the options for these are you can use something like the pill, and you can take it continuously, and that will keep the lining thin. Something like the Mirena is excellent. So the Mirena is used for treatment of precancerous changes of the cervix, of the uterus, sorry. And some people will even use it for cancer of the uterus. So it is really effective at preventing it. The other option for people that don't want to take oral contraceptives all the time or use the Mirena is just making sure to induce a menstrual period at least every 3 months or so. So you can do that by taking progesterone tablets. You take them for about 10 to 14 days. And then on the day you stop them, you would expect to have your menstrual period, and doing that at least every 2 to 3 months to keep that lining thin and reduce the chance of those cancers. The other option is to take something like the mini pill every day. So that will work as a contraception, and it will also thin the lining. And in regarding to the pill, there are some pills that are more effective and some of them that have a lower androgen effect. So what that means is they're more likely to treat the conditions such as the hair changes and the skin changes as well. The common ones people know are Yaz or Yasmin, typically very good for skin changes, or any pill containing norepinephrine. Other forms of treatment, so these are mostly enacted by a GP because they're usually more familiar with using diabetic medications, but metformin is a diabetes medication that if you have pre-diabetes, it can treat it quite effectively to reduce the chance of it progressing to diabetes. Spironolactone is a medication that can help with hair growth, but it has some risks associated with it as well. And metformin can also help regulate menstrual cycles. And what about subfertility? So the one thing I talk to people, there's not many good things about PCOS, but if there is one good thing is there's lots of follicles within the ovary. There's no shortage. And the treatment options, the medication to help induce ovulation or bring ovulation on is super effective. And there's two of these main medications, clomiphene and letrozole. And they are very effective at getting the development of one of those follicles to become mature and cause ovulation. But this should be done through a fertility specialist, because what they'll do is they'll start you on the medication, do regular ultrasounds just to see that it's not having too much of an effect, because you don't want to be releasing 3, 4, 5 eggs at the same time, ideally just the one. And if these don't work or the ovary is a bit resistant to them, you can have surgery for a thing called ovarian drilling. So what that is it's a little bit of some burning of the ovary, and that reduces the steroid levels overall and can help cause ovulation. We used to do a thing called wedge resection, is cut out a bit of the ovary, but it caused a lot more bleeding, and the ovarian drilling is incredibly safe. And some people who have PCOS need to have IVF treatment to fall pregnant. So the interplay between endometriosis and PCOS, so they are two separate conditions. And as much as we know, there's, although they're two separate conditions, their problems can exacerbate each other's basically. There's more delays in endometriosis diagnosed in people who have been diagnosed with PCOS. And that's because I think if someone comes in with a whole range of symptoms and we do some tests and find a problem such as PCOS, then you just say, look, that's the cause of all your problems. But often you can have the two together, and it does mean there is quite a significant delay for people who have both conditions. And it's usually the endometriosis diagnosis that's delayed because it's less apparent. So really kind of going down the treatment pathways for the PCOS, but having a chat with your practitioner to say, look, I think something else here is going on. The reason these two conditions together can cause such a problem is there's a few reasons. So the menstrual cycle will be less regular, so the pain's not as predictable. So instead of someone saying, look, I get pain every month, but at least I know when it's going to occur, if your menstrual cycle is happening very randomly, you don't know when that pain's going to come on, and it's harder to plan your life around it. And the pain, when it does come on, can be more severe because you have higher levels of those estrogen, the hormones. It can cause more severe pain. And also if you can get heavy bleeding associated with PCOS, and that can cause more pain as a result of the endometriosis as well. The other thing is PCOS, as we said, a lot of people with PCOS can have difficulty with weight loss or difficulty with excessive weight gain. And with excessive weight gain, the fat cells in the body convert a lot of other hormones into estrogen. And these really high levels of estrogen, they're the reason there's higher levels of cancer of the lining of the uterus, because that's caused by estrogen. But that also causes growth of endometriosis lesions. So high estrogen levels leads to more growth of the endometriosis and more scarring. And a lot of the management is trying to treat the PCOS as much as possible, but a lot of it is about lifestyle treatments to try and reduce that estrogen exposure from the fat cells as well. So lifestyle changes are very important. Weight loss, and especially exercise, is important, but low intensity and low impact exercise. Hormonal contraceptives can help to treat both conditions. It might be more beneficial to use continuous progesterone treatment or the pill, as opposed to kind of cycling off every 2 or 3 months. It is just as beneficial as thinning the lining in PCOS, but it means you're going to get your menstrual period less often and therefore less pain from endometriosis.